Welcome to this session for Maryland, Okay, very nice. Montana, Silver Spring. Okay. Sorry, I cannot read everything now, but I see a lot of places, exciting, local, and beyond our country. So it's very exciting to be here. My name is Elena Hernandez Ramon. I'm the director of the pre-medical program at the Office of Intermediate Training and Education. And the last 2 previous years we have been saying we want to see you in person, and actually that's true. We want to see you in person, but after being in the last 2 sessions, it's just so exciting to see people from many places in the country and other countries joining that I think this is just fantastic. So I'm so glad to have this virtually and see so many people from different places. We have today an outstanding set of panelists. So thank you for being here. Thank you, Brittany Hardy, for helping today, Dr. Devon and everybody else in the room, organizers. And of course, thank you to our panelists and our participants today, our audience. So I'm going to start asking the panelists to please introduce themselves briefly. If you can include your role in your institution, your name, and then I'm going to go ahead with the first question. So we have a first question, general question, and then I'm going to be waiting for your questions in the Q&A box. Go ahead. So I'm going to start. I'm going to just follow the order I have on my screen. If you want to start, Joan.
Oh, thank you. Yes, good afternoon. Joan Stearman from Uniformed Services Medical School. We're America's medical school, and glad to be here. We're actually right across the street from NIH. So we used to just walk across, but this is great too. We reach so many more people. So I'm the director of admissions, and I've been doing it for so long, I don't even have a resume because I haven't looked for any other job. So, but there are a couple things at our school I wanted to throw out because I know there are people from other countries that because you're commissioned as an officer in the United States, you do have to be a U.S. citizen. So unfortunately, we cannot accept permanent residents but if someone's naturalized, and we have plenty of people who have been, we certainly welcome you, and they have matriculated to the school. The other thing is we also do require a degree from a U.S. college, so that's a little different from probably most of the other schools. And civilians are welcome to apply. We normally roughly about 60% of our class are from the civilian population, 40% have been in the military. And so that's, and this year we actually have more women than men. So the class that just started is 51% women. So, and then of course we look for a passion for medicine. So, but I could go on, but I will end now because we have some other panelists that will give super talks to. Thank you.
Thank you, Joan. Go ahead, Sandra.
All right. Hi, good afternoon, or could it be good morning maybe for some people?
That's true.
Good day, everyone. Sandra Quezada here, really excited to be on this panel again for maybe my 3rd or 4th year in a row now. It's such a wonderful event. I saw that there were some people saying hello from Maryland and from Baltimore. So hi to my folks and friends that are nearby, and also to those of you who are tuning in from far away. I am at the University of Maryland School of Medicine in Baltimore, Maryland. I'm a proud graduate, actually, of the University of Maryland School of Medicine, and I've been living here in Baltimore for 20 years now. So I came here for med school and never left. Now I am the Associate Dean for Admissions, the Associate Dean for Faculty, Diversity, and Inclusion, and I'm also a practicing gastroenterologist with a subspecialty focus in inflammatory bowel disease. I actually had to run over from the endoscopy suite straight to this panel. I'm very excited to be with all of you today, and I think I'll pass the baton on to the next presenter.
Thank you so much. Adrian.
Hello, everyone, and Elena and NIH, thank you for the opportunity to provide information to students about medicine and the process of going to a medical college. This is so exciting, and thank you all for joining from wherever you are. I am Adrianne Jones, Chief Admissions Officer for the Philadelphia College of Osteopathic Medicine, endearingly called PCOM. We have 3 locations: Philadelphia, we have Swanee, and we also have the South Georgia location, which is in Moultrie, Georgia. So Suwanee, Georgia, Moultrie, Georgia, and Philadelphia, Pennsylvania. I'm in King of Prussia currently, located here while it's just a little suburb of Philadelphia and presenting remotely. Let's see, osteopathic medicine. It's the opposite of, as we say, allopathic medicine. And so you'll hear about both of them today, and you'll learn why you want to know the difference. We are too also limited, unfortunately, to only U.S. citizens and those that hold a permanent residence in the United States because of our importance of the residencies, again, as part of your citizenship in the United States. However, we do have students who have actual international documents from outside of the United States. So we can actually work with those records, and then you would be looking at equivalencies and working through an agency that will allow you to assess whether or not that meets the requirements for a bachelor's in the United States, which is your qualifying degree. Other than that, I think I will move on. If you want more details on Philadelphia College of Medicine, as we are answering questions for you today, we want to make sure everybody's got a chance to contribute. Please take a look at pcom.edu.
Thank you very much. Ron, go ahead.
Hi, I'm Ron Bradbury. Glad to be here. I'm the Director of Admission at Virginia Tech Carilion School of Medicine. By way of a couple global things that we like to see here in successful applications, research forward. So we put a primary emphasis on research as part of our qualification and our curriculum. We're tiny. We're going to seat 49 students here on Saturday, if all goes well, the next couple of days. And so we have plans to grow, but we could double in size and still be tiny. We are in Roanoke, Virginia, not Blacksburg, where the main campus is, but just down the road. And you do have all the benefits of the major university complex in that regard. So I'm looking forward to answering your questions.
Fantastic. So we already have quite a few questions in the chat, and let me just try to put together the first one. The first one says, what types of clinical experiences do you typically see in strong MD candidates? And if you can even go beyond the clinical, so include the clinical and other experiences that could be important for your strong candidates. And if we can start with Joan again, is that okay?
Okay, thank you. Typically, I see the emergency room, shadowing there. We do have people that have been full-time nurses. So, we have some people that, had more extensive. I'm also seeing more scribes than I had seen in our, recent years. And then some people have worked in, I know one of my graduates is a dermatologist, and he always hires a couple medical type assistants who are interested in applying to medical school. So I've seen that too. So yeah, whole variety, sometimes nursing homes, and then, rescue squads, EMTs. I know some schools maybe have said they don't look as favorably upon EMTs, but we do at our school. So, but yeah, a whole variety.
Great, Sandra?
Sure. So, and I guess I did mention earlier, University of Maryland School of Medicine is an allopathic MD grading program. And obviously I speak for Maryland, but I think that many other allopathic programs have similar interests. And so in terms of the clinical experiences that we look for and that we think are the most valuable in helping our applicants clarify their motivation for medicine and really kind of understand what you're sort of signing up for, right? What are you getting yourself into? Is those experiences that put you in the clinical setting and allow you to observe physicians and patients interacting together, that relationship and that bond between physicians and patients. And usually we see that best play out in shadowing experiences, like physician shadowing, and then also scribing experiences. The other potential one, which was the one actually I had many years ago, was as a medical interpreter. So again, you're right there in the room, you're observing the interaction, you're actually facilitating the communication. Those are a few examples, and I fully recognize and understand because I remember it's not always easy to find those opportunities to put yourself there in the clinical setting, especially if you're somebody who doesn't really have any connections in medicine, like I was, being myself first generation, not only to medicine, but to college and first generation in this country. I had zero connections at all. I often think people in that kind of scenario could find opportunities either starting out as a volunteer in a hospital, and oftentimes that could be in an emergency room, or it could be in any other potential capacity, maybe on a medical floor. But then when you're there, you're gonna have to like take that initiative to introduce yourself to some physicians potentially and ask them, you know, you can just say, I want to be a doctor. I'm interested in going into medicine. Would you be open to having me shadow you? Or do you know, how a colleague that would be open potentially to having me shadow you? I think that that's a way to start. You could also email physicians with the same sort of opening and ask that. The other thing I'll just add, and it's not 100% yet, but because we feel shadowing really is important and we recognize it's not always so easy to find, we are setting up a shadowing program at Maryland, working with our alumni, basically our wonderful alumni network that's all over the country. So I would say check out our website in about maybe 6 to 8 weeks, and you should be able to see opportunities to find some shadowing experiences.
Fantastic. Is that going to be open to everyone, Sandra?
Everyone who's serious about applying to medical school. Not anybody who really means it and is genuinely interested in medicine will be welcome.
Fantastic. We have a big pool in the area in the Bethesda campus, so that's going to be wonderful. Thank you. And if you can just, before going to the next person, if you can also add, because I saw several questions about how much you are expecting to see, especially now that we have the pandemic and the limitations in terms of number of hours. What is good, what is acceptable these days?
Did you want me to go?
Yes.
Were you ready for me? I was waiting for you to tell me which one. So I'm definitely just wanting to add in more to what Joan and Sandra said. The shadowing experience is very, very critical to you because it is your ability, once you meet your requirements, and if you're chosen and selected for interview, that you're able to articulate why, not only why you want to be a doctor, but what have you experienced since you've been out shadowing, and how much do you understand about this decision that you're about to make. And the experience of working with patients and doctors is live. It is like in the moment, and you are taking your expertise and experience as an accomplished clinician and a practitioner, and every situation is very different. So it allows you to see the doctor in action and the nurses and all those supporting characters that make an experience in a hospital. We're seeing some of the very same areas where Sandra and Joan talked about emergency medicine, peds, anything that relates to nursing homes and assisted living, because sometimes, think about it, when you're talking about coming to the doctor, we're not in our best, we're not in our best shape. And so most of the time you're meeting people who are in pain or who need your assistance or who are in life-saving situations. And so you're able to see everything, not just the whole idea. If you just really enjoy surgeries, well, it's great just watching that, but it's not just about that. It's about the practice of speaking with the other people that make up the patient's supporting network, their family members, their siblings, or whoever it is that's involved in that, and also being surrounding how much, so you can see that it's a team effort. The other members of the support team aren't just other doctors. It could be other members from other healthcare areas that we have programs with, like, the PA, the pharmacist. There's all different kinds of roles where you work and you actually see your doctor working as a team with the nurses and everyone else. So all of that is important for you to observe and to understand. I would also say that, yes, we realize that in real-time COVID, we're still in the phase of COVID right now. It's not over. And it's about the hustle that Sandra talked about. It's like not necessarily because you have connections or don't, but your tenacity to get out there and figure out where is it that I can get as much experience as I can, being open to as many things as I can, and being able to make something of those experiences. So that you're not feeling limited, but you also have to be able to articulate in your interview and as you're going along, like what this is all about. Otherwise, you're just talking about doctors from what you saw on TV, and some of those are really great, but this experience is real time. So I would say it's very critical to your application that it complements it. So I would say it's hard to put numbers. So when you put numbers, people's like, oh, I have 100 hours and I should have done. So it's hours that articulate to active learning. That's what I would say. If these hours are really more about research, that's not what you're necessarily looking for. It doesn't mean that you can't add. You can add think about the whole experience as something as simple as scribing is learning to actually write larger than what you think is there. There's so much going on in the room at the time, and you're able to incorporate a lot in those script notes for your doctor to follow up. So there's just a number of ways in which you can make an impact.
Sounds good. Adrian, could you please just add briefly the need of shadowing DOs for your school?
Yes. So while we don't require that you shadow a DO, I think it's important to have an understanding. Most importantly, we're starting a whole big campaign on understanding osteopathic medicine and how it is a little different. And so if you don't have the understanding of what exactly makes for a doctor of osteopathic medicine, that will be a discount to your application. This year in particular, we're going to be looking for students and supporting our campaign of educating you so that if you don't know who AT Still is, you better look him up after this conference. You absolutely have to know that piece of it. I think it's really critical because otherwise you're not able to really articulate, as I said, the difference between allopathic and osteopathic and why you're on this particular journey, because it is a specific one. So while you may not necessarily find a DO, if you could at least have a conversation. Sometimes students will find letters of recommendation, but you really need to dig deep in there to figure out what the osteopathic mission is about. Thanks,
Great.
Elena.
Thank you. Then we move on to Ron, and I am very curious because I know Virginia Tech is very strong about clinical experiences. So I really want to hear what is your opinion about this, Ron?
Well, rather than add to the list, and I think it's pretty comprehensive, all the pieces you've heard so far, I support all those. We could throw a couple in. Farm tech, I saw somebody with a farm tech question. Something like that is fine in some ways. We've actually seen vet techs who have credible experiences working with the non-speaking animal population. But I think for us, it's less about what you do or how many hours and more about what you've learned through that experience, to echo what Adrianne was saying. We are interested in the doctor-patient exchange, what you understand about that. And we want to see that you're not naive about medicine. If your narrative for being a medicine ends with, I want to help everybody heal all the time, always, ever, then maybe there's a little bit of exposure to medicine that you haven't gotten so that you understand some of the pluses and minuses of that. But really it's hard to quantify hours. It's a question everybody asks. And for your awareness, I mean, we see a lot of PhDs apply, and or nurses or someone who's been with a clinical license for years and years, they may have 7, 10, 12,000 hours of credible experience. We see rising undergraduates who are, rising seniors who are the minority anymore in terms of quantity, and they may have a few hundred hours. And to us, it's less about the number of hours. If it was just hours, we could process our applications automatically and be done. But we read those experiences and we want to see what you've taken away. And we want to make sure that when you get into medicine, it's not going to freak you out and you're going to get out of medicine. We want to make sure you have an informed perspective going in. And so that's what we're looking for. And you can write those experiences. You can write a very compelling narrative, very succinctly with a few hundred hours. And in our world, you're very, very credible. I'll take that as a segue. For one thing I would say is, for me personally, I like to see explicit points about what you've learned. I was a scribe, and then you tell me a story about a patient you saw. That doesn't really help me. Tell me what you learned. Why was this experience relevant? How does it help you, your motivation to medicine, your understanding of medicine? Don't just tell me stories, because the story is ambiguous. And while it may mean a lot to you, it may mean something else to me or one of the other folks who read your application. So that's my perspective on the clinical, and I could go on, but I'll stop.
Fantastic, thank you. So let's just change the move to a different question, and then we may go back with some other similar questions to the previous one. So I have a couple of people interested in red flags. What are some of the red flags you have noticed in your applications and that you review? And we may start now in a different order so people can hear different opinions. And then if you have similar opinions, don't worry about repeating. If you have something else to add, I would ask the rest of the people. So Adrian, I don't know if you want to start with this one, red flags that you see in your applications.
Yes, I would say that at the end of the application, because it's very comprehensive, it gives you a perspective of your academic picture, your extracurricular, the work you've done in the clinical area, your background. So when you get to the end of the application, you really should have, as we use a holistic review, you really should have an understanding of the whole person. And so if the academic piece isn't adding up, then it's not that nothing makes sense, because it just depends on what that combination of academic things are, but you're looking for an understanding of the student's journey. And so sometimes the questions aren't answered carefully. You're not really taking your time to go through to describe some of the experiences that you have. Even clinically, we're looking for more than the kind of entry you would have for like a resume. It's not just how much time you spent and when you were there. It's like, what did you gain from that experience, and why is it relevant to being on the application? So as you are pulling those together, please take time to really be mindful of the words that you use and also how you're articulating your experience. I would say one of the other red flags is so if the application doesn't match and you get to the recommendations and there's a totally different kind of experience, like the student was kind of like, okay, like you're good, your academics are good, and then you get these recommendations that are just like, oh my God, this is the best student ever. And you're like, wait a minute, is it, what's happening? So as you have your recommenders who are writing on your behalf and you're pulling your application together, it's really important for that. You could even have a really strong academic student, and then the recommendations, they kind of fall flat and you don't get that feeling that this is the same person. So it works on both ways. And so you want everything to flow together well. It doesn't have to match exactly, but you want to make sure you're speaking of the same student, right? And then because we'll have an offering of both virtual and in-person interviews at some of the colleges you'll hear from today, you want to make sure that you show up like your application. Like if you talked about these things, you have a really nice personable essay, you don't want to not be able to articulate that's a wonderful thing, and that these things stand out about you. I would also say that really strong academics and then nothing else to go with that is always a red flag. Not a good sign for us. Even though people think I have certain scores and I should be this and that, what I would tell you is that in our most recent experience, medical experience in my family, we turned away the fellow. We turned away the second person who came and told us about all of our experience. And we went with a doctor who said, I have an architecture for the surgery. Here's the people that will be touching you. And here's what I want to tell you about how I prepare each day. That's what we were looking for. And again, when I think about the creativity that happens within the connection between your doctor and the patient, that is what is key. Oftentimes, one thing that I learned from the many doctors that I support and serve at PCOM was oftentimes we forget about the patient. So if your application does not clearly zone in on the fact that you kind of get it, that it's not really about you, it's about the people that you will serve, that also is a red flag.
Okay, fantastic. Any additional comment about that? Now that I am seeing tons and tons of questions.
I'll throw a couple of little process errors. I've already seen it this year where you copy and paste. Do you want to go to the wrong school? So you're really interested and can't wait to go to Hopkins. That's a deal breaker. I've seen somewhere they've had to write and say, due to my inattention to detail, I didn't enter anything. I put a placeholder in this AMCAS box. Those things are like immediate red flags. Another succinct one is when you get a line for us in a letter of recommendation that starts, although Susie sometimes didn't get along with her classmates. Those are the things that sort of jump out because most letters make you sound like Albert Schweitzer and Mother Teresa. And if there's any kind of a comment there that is less than effusive, it kind of, we want to know why. Let's see, for VTC, I always say very simply, we're looking for smart and nice. Smart's really easy. to ascertain in American education, brain power is pretty well quantified in lots of different ways. And by the time you get here, we see lots of indications of your academic preparation and intellectual acumen. We just need good citizens who are kind, because we have a very collaborative environment. And so if your application speaks of someone who doesn't resonate with what we offer, that can be a red flag. If you're, super competitive, you like to crush people on your way to the top, that's fine. It's probably not going to work out as well here. And so those are the kinds of things that jump out. That's a little bit more of a holistic answer, but we see a lot of little teeny mistakes. And because it's such a nuanced evaluation, if I have 50 applicants with a 525 and a 4.0, I'm going to skip over the 3 that had typos or a mechanical error in their application just by virtue of the fact that I can. So.
Right. Yeah, I second that, Ron. We've had people with great credentials, and then we see the typos and they're like, well, are they going to be that careless when they're filling out prescriptions, and get things, mixed up. And we also really look for team player, because in the military, it's, one fight, one team. And we don't want, if we get on the letters that everything was solo, we won't invite that person for interview, because you have to definitely work as a team member. When you're deployed to Iraq and Afghanistan, you don't want someone who's just looking out for themselves. So and all the other things that Adrian said, I second all that. It's just the same with you, sis. So thank you.
Great. Okay, so let me go to the next question. Probably just one person. I don't know if Sandra wants to answer this one. I come from an undergrad university that provides negative evaluations and a satisfactory, unsatisfactory in view of a GPA. Would you recommend I reach out directly to program directors to see how each program handles the situation?
I don't think you need to, because when you submit I guess, I'm speaking for AMCAS, but I bet Acomas does the same thing. They actually will validate the transcripts and actually sort of do a translation, so to speak, so that when we're comparing transcripts and GPAs, there is some sort of consistency across there that actually this national application system accounts for. So I don't think you need to reach out to every single admissions director or officer to explain that, because I think that actually the application system is going to help compensate for that. Now, the only time where I say it can be for us, and I think for any school that requires committee recommendation letters, and some schools don't provide that, then sometimes it could be helpful to just submit an additional letter to say that there is no committee letter available, and that's the reason why you're not including that. But I don't think you need to reach out specifically to explain the nature of the transcript or the grading system at your school. I don't know if anybody else has a different opinion, but that would be my recommendation.
I would agree, Sandra. I think that the other thing is we talk about alums and research on that institution and find out if someone else has attended that school where you're coming from. And usually we have a pretty good, decent archive of different college transcripts, and we can research if there's something that's very unique about your school. But anything that the registrar can send along that assists the actual processing of applications, Sandra's right on point there.
Mm-hmm.
Sounds good. Okay, so a very quick question for everybody. How quickly do you want that secondary application to be returned back to you? Joan, you want to start?
Yes, when we send them out, and I think we're probably the only school that doesn't charge for it. So it's not like you have to wait till you can get a check or your visa. So we actually ask 3 weeks, but there are times that military people, especially, they can be in the field, or ROTC has summer training. So we're glad to give an extension, but the only thing is, or we work on a rolling admissions basis. So if you have everything in, and that's the only thing you don't have those in, and ours are pretty simple, just kind of 3 short, kind of questions. So it shouldn't take weeks and weeks, but normally we ask them to come back within 3 weeks, right? Mm-hmm. Thank you.
Sandra?
Yeah, we actually don't have a recommended time frame that we say you need to give your secondary back, but just as Joan was saying, we do have rolling admissions, which just means generally speaking, every part of the process you can do earlier will only benefit you. So the earlier you submit your primary, the earlier you get the secondary back, and the earlier you interview means that the admissions committee is ultimately going to sit down and discuss your application earlier when there are more spots available in the class. So it's really the best way to give yourself an advantage. So for us, again, it's not so much the difference of time between your primary and your secondary. It's more just generally speaking, how early was everything done and ready? The one caveat being, let's say you're somebody who submitted your primary already in June to, whatever number of schools. And then I see that you got your secondary into us, 3 or 4 months later, right before the deadline. Then that says to me that we were not on your initial list of schools that you applied to, and now you're sending out your second or third batch. And so we're sort of clearly, that tells me that we're probably lower on your list in terms of where you're interested in going, which doesn't mean that I won't necessarily interview you, but to be honest, the deadline is really not when you want to submit your application again, because you really want to be applying early. So you're already setting yourself at a disadvantage if you wait that long.
Yeah, I always tell people the only time you want to wait for the deadline is when you're paying taxes on April 15th. So
Yeah, I would agree. I would also say early is fine, but don't go so fast that you don't answer the questions.
Absolutely.
Secondary is super important for us in terms of the esprit de corps of our school and those sort of intangibles. And we got some secondaries back the day after we sent the invitation, even before Student Dr. Net had our questions posted, and the answers came back. They were sketchy, and some people just copied and pasted in generic essay questions that were sort of in the ballpark, and that's, to me, a waste of $70 and my time. So I would say not so fast that you cut corners, but and never ahead of a chance to read it at least twice or have someone else read it.
Oh, and if you don't mind me jumping in, it's what Ron said about studentdoctor.net. I personally don't even go to it, but I do have some staff members, and they're like the FBI, and even without a name, they figure out people. And so I just would be very careful, because once you put that on, it's public. And believe me, I'm like, how did you ever figure that? There's no name, and oh, this and that. So, and it hasn't actually benefited the applicant. So it's officially not passed on to the admissions committee, but it's just not something that I would recommend, right?
Fantastic. There was also there's several questions about stats, and I really invite our trainees here to go to MSAR and check the information that is already there. But there are some questions regarding unbalanced MCAT and GPA. How do you evaluate that when you are reviewing applications? Is there an MCAT that can really make up for a low GPA, or vice versa? Anybody who wants to start?
It's not formulaic. If they're both low, you have a bigger hill to climb than if one is up and one is down. The last study I saw from the AAMC said in combination, they're the best predictor of success on step one. Either one in isolation isn't. So whichever one is low, if you feel like you have a narrative that you need to explain it for us. But we admit people from our range, which is here is 504, all the way up to the tippy top. So we take the range seriously, but we just need to, I don't think there's a magic combination anywhere. The table A23 on AMCAS's website or AAMC's website will inform your thinking on that if you haven't seen it. So.
Right. The same with us. We've taken people even at 500, but of course, the stronger the better and everything. And sometimes people have written, maybe they have a really good MCAT and their GPA was lower, but then they write that. I know one of my graduates, was literally, living in a car, and her pre-med advisor definitely brought that into the letter. I don't think the applicant actually did, but the pre-med advisor. And so, and she was working and trying to go to school. So her GPA, and, she did fantastic here and did well. So she was able to do, so that was definitely a plus. But so, the same thing, there's no exact combination that we have. Thank you.
I love that. You're looking for the person at the end of those numbers, the
Right.
GPA and the MCAT. And so the other aspect of it is at some point when an application comes in, if there are problems there, in any case, you would want to make sure that the applicant has done some legwork. So you might be looking for post-bac. You might be looking for ways in which you've, really done some assessment of yourself in general. You say, okay, I know I wasn't strong in this, and here's where I need to pick up, or I've got to get ready, because literally once you're coming into medical school, it's a serious transition. At the graduate level, it is a beginning of an assimilation of lots of information. So it's not like you're going back to get English 101. It's a different experience entirely. And so the less foundation work that you're doing coming in, and that you've taken care of that, the better you would be in being able to move forward with this new way of synthesizing information and preparing for what is going to be the next level. Sometimes students get caught up in credits and things, and again, it's a combination of that. So here's what it is. It's one of those kind of things where if you had asked me, this is what I would say it's not like that. The school's not asking you what you think. They've said these are the requirements we have, meet them or greet them, and then move forward with other aspects of your application. So take very care with, as you heard from the secondary applications, your answers and responses are equally as important, the timing in which it arrives. So pay very attention to every aspect of what we're asking you to do. That's obviously like number one. And then the reality is that sometimes it is what it is. What you see is what you're going to get. And then we're going to ask, well, what did you do with that? And so, and what did you make of that experience? But you can't expect to have a very poor undergraduate or even a graduate experience and expect someone to overlook that. So we would be looking for what's happening with that, and how you develop that academic record. But it needs to be strong. It needs to be without question. And you don't want the admissions committee to spend time asking questions like, oh, they're not going to academically make it. Sometimes it's just you have a score or a GPA, and that's a blip. You look back because you can see everything laid out. You know how it works. They lay out all your courses, all your GPAs. So we can kind of see a year or two that maybe was a foundation or there was a bad experience. All of that is very laid out. We can kind of see some of your experiences. And then as you write your essay, you'll talk about some of those possibly and give us blow life into it. So we're not left trying to figure out what's going on.
If I could just jump into about the MCAT, just to say, I hope everybody appreciated and heard the broad range of MCAT scores that people get into medical school with. Similarly, as Joan said, if you're at about 500 or above, at Maryland, we've accepted and matriculated students with that full range of MCATs above 500. So we sometimes see people who had like a 515 and they keep retaking it because I think they need a 520 or 525. And I feel so bad for those folks because you were just fine with your first MCAT, and that's a lot of money and pain to keep retaking the exam. We actually did an internal study, and we were able to show that there was no difference really between our student that came in with the 501 versus the one that came in with the 520 in terms of how well they did in medical school or in step one. So we truly treat it as a pass-fail exam in many ways. I would say at the same time, if you scored in the 400s, you should retake it. I think I would recommend retaking it to be more competitive and also show that you are able to be successful with standardized tests, which unfortunately are part of medicine. And I also think, again, because people don't get that feedback, they apply with scores in the 400s, and that's also time and money wasted. So that was just the other piece I wanted to add.
Fantastic. So a lot of people are asking about numbers and ranges, and I see that many of them are not familiar with MSAR. So you can actually find these ranges in the Medical School Admission Requirements website, and Dr. Hardy just posted the website in the chat. If you want to go and open and explore that website, you need to pay for that, but it's not much. I think it's $28 per year, $36 for 2 years, and I think it's a very worth it to have that information in only one website. The next question, I'm trying to see how to combine so many questions I have for you. But one I've seen in several people asking is how DO is different from the MD, probably some difference from the Uniform Services curriculum. What are the particular highlights of Virginia Tech or University of Maryland? So I don't know if we can take just a couple of minutes each to tell us what is that unique thing from your school. And I think that that's going to be helpful given that we have a good variety today. Do you want to start, Joan?
I'm sorry, just about our curriculum, what's different?
Yeah, what is different in every,
okay.
right?
Okay, thank you. Yeah, so we have changed from the 2-year basic science to the 2-year clinical to the 1.5 years of basic science and the systems based and 2.5 of clinical. And I guess one of the exciting things for us, which is that our students can travel. They do their clinical throughout the whole country. So if you like to travel, if you don't like to travel or live elsewhere, then we're probably not the school for you. And so you could be in everyone's a commissioned officer. So you could be in the Army, but still do a rotation in San Diego at the Navy Hospital. So and then it's all paid for too. And our students are paid about $73,000 a year to go to school. And about half of that is tax-free, but there's no free lunch. So it is a 7-year obligation after all your training, but you're working as a physician. We do have also some military training, but it's not at all, Green Beret training. You don't have to worry, or the SEAL training. So, but you would do some, and we do have a field experience while you're in medical school, and you'll go live in the fields, and the first year you'll be the patient, and then the last year you will be the 4th year you'll be the doctor. So I think that's certainly, my niece did the health profession scholarship, but she didn't have any of those experiences while she was in medical school. So our students start while in medical school. Yeah, thank you.
Just a quick question, Joan. How important is for you to have students with military background or experiences before applying to your school?
About 40% who matriculate have had some, but I tell my military people that in itself won't get you in, but I also tell them you've walked the walk, so it will be a plus. And we do, as I think everyone else has alluded to, we do the holistic. So it definitely is a plus, because we know anyone who's been in the military, they wouldn't want to come to our school if they didn't like it. They would definitely go elsewhere. So we know that if they're applying, they definitely are interested. They definitely want to continue to serve, and that's really important to us, right? Mm-hmm.
Sounds good. Thank you, Sandra.
So at Maryland, we have a 4-year curriculum. The first 20 months, so just a little over 1.5 years or so, are what we call our pre-clerkship curriculum, which is more classroom-based, a mixture of lecture and small group or team-based learning kind of didactics. That's mostly just in the morning. Most of your afternoons are open, but some afternoons are spent in the clinical setting, working with patients, learning how to take a patient history, how to perform the physical exam. And then once you, towards the middle end of spring of your 2nd year, then you begin your clinical clerkship rotations, where basically every month you're rotating through the hospital, being part of the medical and surgical teams in, medicine, psychiatry, pediatrics, OB/GYN, neurology, surgery, et cetera, multiple different subspecialties. And this is, the exciting time where you're also just, feeling out the different specialties and figuring out what are you going to do with the rest of your life. And then basically at the beginning of your 4th year, you apply to residency. I think that our curriculum is very similar in many ways to the format and method of the curriculum that you would find in a lot of medical schools. And maybe what makes us unique, I think, is our location. I think the patient population that we work with is amazing. And if you're interested in working with a diverse patient population, then you should come to Baltimore. And, one side note, obviously, we'll hear more about osteopathic medicine. I will say that both DO and MD graduates are now applying through the same residency application. As you know, I think that's been a couple years now. So you will have the same opportunities as far as training beyond medical school. Generally speaking, I think we tend to see more often some of the more primary care fields be more common among DO graduates, although not exclusive by any means. And similarly, you probably see some more specialty and subspecialty fields among the MDs, but we also have plenty of primary field graduates as well.
Great. Adrian, if you want to answer that question and also try to highlight the differences between the DO and the allopathic medicine that they are asking about too.
So they are both licensed practitioners, and specific to the Doctor of Osteopathic Medicine is a particular training in osteopathic manipulative medicine, which complements the whole person type training that an osteopathic medicine doctor or a physician would go through, where you're looking at the entire person rather than just the symptoms, and you're looking at systems of the body. The other focus is for an osteopathic doctor, as Sandra mentioned, being in the family's practice area is one of the major areas. But again, in all subspecialties, surgeons, all of that, everywhere, is the focus on preventative health. That is really a very big part of what we do. So preventative health is in understanding how the body functions. For example, when I went in for some osteopathic medicine, manipulative medicine, I had been sitting and I was having some issues with my hips. And there was lots of questions around not just the ergonomics of where I was, but what else was going on, and looking at all the systems in my body to determine. And then there was some manipulation that was done by hand. So that training in the osteopathic medicine area allows you to put your hands on the patient and make some adjustments, and then having more conversations about the care around that, whether that's the foods you're eating, the amount of stress that you're under. There's a lot of different things. So a lot of times students will hear mind, body, and spirit. Don't say that. That one is so kind of like cliche-ish, but it also makes it sound like there's some kind of whispering thing that's going on. But it is a combination of looking at all of those systems together and seeing how they impact one another, and as a result, what is happening with your body. Is that helpful?
Yes, thank you. Ron, go ahead.
I mentioned earlier that VTC has a research piece. We also have a pretty strong clinical. We get you into clinical rotation your second week in school. We use problem-based learning. So by the end of 2 years, you've been through in small groups, I think it's 96 patient cases. One unique piece of the PBL here is you get to meet the patient. So you have a week long going through the case with 6 other classmates and a preceptor or a facilitator. On Friday, you get to meet the patient and the provider. If the patient is not, if the patient is passed, you get to meet someone with the same condition. And it gives you a chance to ask the kinds of questions that are very important for medicine, but not curricular per se. What was it like when your hair fell out? How did you feel when you went to school? Were you able to keep your kid in school when this diagnosis? All those sorts of things you can hear and dialogue directly with the patient and the provider. How did you figure out this diagnosis? Why did you jump to that particular test? Those sorts of things. But the research piece is also very important. You'll do over the 4 years here, you'll do a publishable quality research project. It will be funded. You'll have PIs and clinical researchers paraded in front of you. We not only facilitate it, we sort of force you, make you do it. If you don't like research, then you shouldn't think seriously about matriculating here. We think it helps down the road when it comes time for residency. We think it's an added bonus on your sort of CV that certainly doesn't hurt. But we do it primarily because we're trying to produce clinicians who are going to be have facility with research. We're not producing primarily people we expect on a bench someday, but we want people whose practice and patient care is informed by the latest research, and they know how to engage that in a meaningful way as a provider. So that's the VTC in a nutshell.
I would like to add, thank you, that we have a simulation center that's state of the art. And so our students start early, like the first week with patients, but they also get to, we pay actors and actresses. So I think that has helped too, when they're in their training. So that's been a real plus that the students have told me they really like. In fact, one school I was at, I said, oh, you have a really nice sim center. And they said, oh yeah, we came to your school and we copied a lot. And I go, well, that's good. About 100 institutions at least have come to visit us. And, we're the federal tax schools, you pay your taxes, so you might as well, benefit from it, definitely. So thank you. So if anyone hasn't been to it and they're interested, we'll certainly be glad to arrange for you to visit it. Thank you.
I was there and it was very impressive, I have to say. Yes, go ahead, Adrian.
Oh, I was just going to say that we also, we're not connected to a hospital system, but we have community clinics, which are really awesome opportunities for students to get hands-on. And we have the sim labs, and it's really training that's similar to an allopathic doctor. But I wanted to also talk about some other things, as far as the community service also that works with different groups within our communities that actually drive some of the diversity around our communities. And that aspect of it, I think, is also really critical as well when you talk about real live hands-on training. And that research component is available as well. But I think I love the community clinics, because one of the things that's really interesting, I don't know if we have any Jay-Z folks out there, but Jay-Z has this piece in his comment when he sings a particular song. He talks about life ends where the church, life begins where the church ends. And so what he means by that is once you come out into the community after church and you talk about how you give to the poor, how you actually demonstrate that is very critical. So all of the learning can occur just in the classroom setting. And I want you to make sure that you explore each of these places that we're talking about out beyond the traditional things that go on. What are other ways in which you'll work with other student organizations and groups, cultural competency? There's all kinds of things that can contribute to your learning and education.
Fantastic. We still have a lot of questions, so let me try to summarize and cover the more general ones. Just making sure, some people are asking about Casper, but it looks like none of you use Casper for evaluation, right? Okay, great. So we're gonna skip that one and we can talk about that question in our Q&As, and I'm gonna send you the specific link. Topics to avoid in a personal statement. Controversial. And you can, just without explanation, because we don't have a lot of time, but if you can just mention a couple. Can we start with Joan?
Well, I just recommend that people be themselves, in their statements, because if you try to copy someone went to medical school, it's not going to go well. And I guess as mentioned earlier, being careful of typos, even though they're, in the old days it was really easy to have a typo. Now with word check, it's spell check. So, but I would, and I definitely would, bring up a lot of probably controversial issues in the person. We're looking for a passion for medicine, why you want to be a physician, why you want to go into medicine. So we have ethics groups, and we do have, there's plenty of time while you're at school to discuss controversial issues, right? Thank you.
Right. So Joan, I just want to try to include something else here. If you feel like something shouldn't be mentioned, like mental health issues, religion, political views, etc. Anything else to add, Joan? We continue with Sandra.
Yeah, thank you.
I would say more than just like specific issues to avoid, more just some themes. So when you think about what is the point of the personal statement? The personal statement is supposed to be your opportunity to tell us your why, why medicine, what is your motivation for going into this field? And if I think a big don't or thing to avoid is if I read through your personal statement and I finish and I feel like I still have no idea why you want to go to medical school. And that happens more often than you think. So that I think is a big, loss of opportunity. And so I would definitely avoid getting too far off track or trying too hard to stand out with this very, very sort of unusual thing. Just tell us your story. Tell us why you want to go to medical school and to become a physician, it doesn't have to be super flowery or unusual, a personal statement. In fact, you don't want to stand out for the wrong reasons. The other thing I would say is, we are looking for people who are professional, who are humanistic. And so the opposite of that would be a problem. So if you are describing others, whether they are patients or physicians or healthcare providers, in a way that is unprofessional, then that's something to avoid, and also to avoid dehumanizing patients. And we see that a lot, actually, and I don't think people realize they're doing it. But when you, for example, want to share about a surgical procedure that you were privileged enough to be able to observe, to just talk about human beings by body parts and procedures is very dehumanizing. Again, just remembering that there's a human being there who is undergoing a very, life-changing moment, for example. So just being very humanistic in how you discuss the patient experiences that you've had as well, not only your own experiences, but certainly how you present your view of other patients, I think is really, really important.
Yes. Adrian, do you want to go ahead?
Sandra took it. Sandra said it all. Man, it was great. I would say I think about it as everything that Sandra said, and think about it as your unique bedside manner. Like everything about who you are should be coming through that essay. And if it does not serve, get rid of it. Plus what Sandra said.
Sounds good. Ron, do you have any additional comments about that one?
Yeah, I would just add, avoid the diatribe, avoid the social rant about whatever your passion is. We want to admit doctors, and we expect them to be passionate about things. We don't want to admit polemicists or someone who's passionate and sees medicine as a means to an end. So medicine first, passion about whatever is fine, but keep it in check and balance it out. So
fantastic. Well, the other question I have here in the last 2 minutes is, what is the importance of research for your programs? And I think many of you already mentioned that, probably that in combination with how important it is for students to take a gap year and what to do in that gap year. If you want to give a brief answer to that question, any of you?
I'll say gap year, if you have a choice, sometimes you don't and you have to. And if you want to come to VTC, research is important, and whatever you're doing, whatever medical school, you have to hit the ground running. So focus on learning, not checking boxes. I don't care where you get what you get, just learn it well so that when you get here, the volume doesn't overwhelm you and you can keep up with it quickly.
And make the gap year count. I would say read Mindset by Carol Dweck or When Breath Becomes Air. And just be in touch with yourself, so when you show up, you're ready to go.
Fantastic. Any additional thing, Joan?
Yeah, just if you don't need the gap year for academics, then definitely we recommend the more medical exposure, especially something like like the medical scribe, where you really get involved. I mean, we don't want to have someone for a whole year just walking around behind a physician. That would be. But if they can really get involved and it would just help them with their when they're dealing with patients more early on in their medical career. Yeah, thank you.
Okay, anything to add, Sandra? Okay.
No, I think I'm good. I agree with everything that's been said.
That's good. Okay, so you have 1 minute. Mental health issues, should I disclose that or not?
I can start off. It kind of was almost mentioned earlier. It sounded like when we were being asked about controversial topics, I don't consider it a controversial topic at all. And I think that if this is part of, again, any part of your story that is a genuine, authentic part of who you are and part of your motivation, I think is absolutely fair game to include. You also shouldn't feel like you have to, write about that if you don't want to. But if you feel like it is important and it's really about, again, being genuine and presenting yourself fully, then by all means, I think that including that, and I would say the important piece and how you're framing it to think about is, framing this as a lived experience that you have that potentially could really be a strength, right? It could allow you to empathize with patients who have mental health challenges, and just how you can bring that into medicine and bring a unique perspective that we maybe don't have as much as we need, right? So thinking about that, also I would argue, and this is for mental health, it could also apply for academic difficulty or other things. I think that a lot of the time we really feel good and are reassured when we see that somebody is open to reaching out for help and taking that help, whether that is for help with mental health or with academic difficulty, et cetera. When we kind of see, because of the way that you're sharing your story, that you're sort of like, but I did it all myself, and I didn't need any help with this and whatever, and sort of somebody who's very, very hyper independent, I would argue, that's actually a little bit of a red flag for us. It worries us because everybody needs help sometimes. And trust me, we all need help in medicine to get through the career. Having done it myself, I can tell you. And so, if you present it again as this was a challenge, and maybe it's a challenge that I've overcome because I've reached out and I've done the work that needs to be done. I have somebody that helps me with this, or a team that gives me the support that I need to continue to be successful. So the only time it could be a red flag or a problem would be again, if it looks like you're sort of flailing on your own and it seems unresolved, then that would be that would be concern.
Thank you for that word. Okay, we need to leave. It's 3:11 now. Thank you so very much to the panelists. It was great. This was great. I think we answered a lot of questions. If you have more questions and general questions, you are welcome, the audience, to come to our Q&A sessions, and Dr. Hart already put the link there. And thank you, Brittany, for putting all the information there so quickly. Thank you. That was fantastic. Thank you again, everyone. And just go to the next session. It's going to be very exciting too. Have a great day today. Bye.
Thank you so much. Thank you.
Thank you for coming, panelists.
Thank
it was
you so
fantastic.
much.
Thank you.
Okay. Bye-bye. See you.